introduction, and thank you for having me. It's a great honor to be here today. So there were some very wonderful abstracts presented at DDW for functional and motility diseases, so I'm going to get right to it. And we're going to just go right to it, and we're going to start from the top to the bottom. So starting with esophageal disorders, this was actually a nice study looking at patients who had ineffective esophageal motility. As you all know, there was a change in Chicago criteria in the past year from Chicago 3.0 to Chicago 4.0, so they redefined how we actually define patients with ineffective esophageal motility. And what this study was looking at was specifically patients who have a high rate of, high proportion of failed swallows. Do those patients who also have esophageal contractile reserve have any change in terms of their reflux burden? So just to give a little background here, when we have patients who have high failed swallows, one of the things that's recommended is to consider doing a multiple rapid swallow evaluation where you have the patient do 5 rapid swallows. And what you're looking for, if you can see here, is basically a vigorous response. And if you have that, that's thought to be an intact contractile reserve versus if you do not have that. And there's actually a mathematical equation that you can use to try to determine if that's actually present or not. So in this study, they looked at 400 patients, of which 160 met traditional Chicago 3.0 criteria for ineffective esophageal motility. They then further subdivided these patients into whether or not they had a low number of failed swallows versus a high percent of failed swallows, which they defined as more than 50%. Of those who had a low failed swallow, they also looked to see how many of them had ineffective swallows. The new Chicago criteria also includes if you have a low percent of failed swallows but have more than 70% ineffective swallows, that's also considered to be adequate to make a diagnosis. And of the patients who had high failed swallows, they then also did the multiple rapid swallow evaluation. So they further looked at the actual acid burden by doing a 24-hour impedance test on these patients. And what they found is that those patients who had high failed swallows and a lack of contractile reserve, so this group here, had an increase in both the mean total acid exposure time as well as the proportion of acid exposure time. And this was true also for proximal acid exposure. They further looked at the total number of reflux episodes for these patients and actually found again that those who had high failed swallows, so there were more than 50% failed swallows, and a lack of contractile reserve, had increased number of total reflux episodes, percent of reflux episodes, and proximal reflux episodes. They did a multivariate analysis controlling for several factors, and they did find again that there was an increased odds ratio if you had a high failed swallow and a lack of contractile reserve. And this is compared to people who have normal motility, people who have low percent of failed swallows, and those who have an intact contractile reserve. So basically the conclusion is that we should be doing this testing on patients. It could give us some indication of their acid burden that they may be experiencing. This is a really nice study looking at patients with gastroparesis and functional dyspepsia. So what they did was they looked at 944 patients who were in this gastroparesis registry. And at baseline, 224 had normal gastric emptying tests but met Rome 3 criteria for functional dyspepsia. The other 720 had gastroparesis. There was no significant difference between the two groups in terms of demographics, except for slightly higher prevalence of diabetes, as you might expect in the gastroparesis group. And there was also no significant difference in terms of predominance of symptoms or baseline symptom severity. And they followed these patients for 48 weeks, and not all the patients agreed to participate, but the ones who did, in the gastroparesis group, they were able to retest 189 patients in the gastroparesis group with a repeat gastric emptying study. And they now found that 42% actually had normalization of their gastric emptying study. So if you look here at the bottom where you can see the blue and the red lines, you'll see that the blue lines are actually the baseline 4-hour gastric emptying test. So you can see here that this was the baseline for both groups. And then subsequently at 48 weeks, there was a significant difference in terms of their gastric emptying studies. Similarly, they did the same thing in the functional dyspepsia group, the ones who had normal gastric emptying at baseline. Again, 60 patients were agreeing to participate, and they found that 37% now had delayed gastric emptying. And again, the baseline characteristics were very similar in both groups, but there was a significant change afterwards. They looked in to see if was there a change in A1C level, was there a change in medication use, anything to predict this, and they found no significant difference between the two groups. And they also looked at symptoms, and they found no significant difference at 48 weeks between the two groups. And if you remember, there was no difference at baseline either. Interestingly, and they didn't explain why, but some patients had full thickness biopsies that were performed for different reasons, and they actually found that both groups, both functional dyspepsia and gastroparesis groups, actually had a loss of interstitial cells of Cajal and a decrease in CD206 positive macrophages, which, if you remember, are the healing, protective, sort of good macrophages. So their conclusion was that 41% of patients had a change in their gastric emptying status after 48 weeks, but no significant difference in symptoms. So that really suggests that maybe gastroparesis and functional dyspepsia are actually on a spectrum of disease. So we should consider that when we're evaluating patients and treating them accordingly. This was a little more of an observational study, but this was a study looking at patients with functional gastrointestinal disorders who met Rome 4 criteria for this. They had about 80% female. They wanted to see were there specific factors that were associated with increase in bloating. And basically what they found by doing a multivariate analysis was that there was an increase in bloating in younger patients, those who had functional dyspepsia, functional constipation, those who had increased abdominal severity, and those who had more severity on a PHQ-12 somatization study. There was no association with anxiety, depression, and sleep disturbance. So these are risk factors that you should consider in your patients who have functional dyspepsia. They may be more likely to have more severe symptoms. And this was their multivariate analysis here. One interesting thing was patients who had an overlap with IBS, interestingly, had less bloating. They really couldn't explain that, but that was something that they found in their study. There were a lot of really nice studies done in terms of diet. So as you know, we don't have a lot of great data in terms of IBS and what diet to recommend. FODMAP diet has some data, gluten-free diet has some data, but there's still a lot of questions to be answered. So this was a study looking at 110 patients. They looked at all subtypes of IBS, and they did a really nice study where for the first 2 weeks, they basically had patients on a very low FODMAP, low gluten diet, and then they introduced the patients into one of 3 categories. Either they gave them FODMAPs, they gave them gluten, or they gave them a placebo. They did that for a week, then they had a week washout, and then they gave them one of the other interventions. So it was a 3-way crossover placebo-controlled trial. What they found were that patients who received FODMAPs actually had statistically different IBS symptom severity scores, as well as significantly higher abdominal distension. There was no significant difference between the gluten and the placebo groups, both within each other or individually. And there was no change, though, in frequency of abdominal pain, severity of abdominal pain, dissatisfaction with bowel habits, or quality of life. They also looked at subtypes of IBS to see if there was a difference, and there was not. But this does suggest that FODMAPs specifically may actually increase at least some of the symptoms of IBS. This was another diet study. This one was looking at specifically these powders of reintroducing FODMAP powders. It's actually a preliminary study, so there's only 26 patients reported to date. They looked at patients who had fairly significant IBS. Their IBS-SS score was fairly high at baseline. And what they had them do was meet with a dietitian, and then they had them go ahead and get put on a very strict low FODMAP diet. And then they slowly reintroduced them one at a time with these powders, about a week at a time with 2 days of washout. And what they found was that putting patients on a very strict diet initially caused pretty much 95% response rate for a decrease in IBS-SS score. But when they reintroduced the FODMAPs, they found that mannitol and fructan specifically caused an increase in the scores, which is suggesting that those may actually increase those symptoms. Again, this is a very small data set, though, so we should take that with a little bit of caution. They also looked at somatization and depression, and they found that the strict diet improved both of those, but interestingly, fructose also did, which, again, is a small data set, so I'm not sure how much we can infer from that. And then this was another diet study. This is a domino study. They looked at patients basically randomized to either a low FODMAP diet or a medication called odolonium bromide, which we don't really use here in the United States as an antispasmodic medication. It previously was a part of Librax, which is no longer available, with a benzodiazepine. So this medication, they basically randomized patients to either diet or medication for 8 weeks, and then they had a 16-week follow-up period. And these patients were primary care patients, so they looked to see how many of them actually had IBS. 70% of the patients referred actually did have IBS. And what they found in all of the patients who received diet compared to medication, there was a significant improvement in their IBS symptom severity score, and more so even in those who actually met Rome 4 criteria for IBS. And this was sustained in the follow-up period as well. They also looked at quality of life, anxiety, depression, somatization, and they actually found improvement in both groups, both diet and the medication otolimumab bromide. Female gender was predictive of response to diet, whereas if patients had somatization, that was predictive of response to medication. So both interventions had improvement, but it looks like the diet intervention had greater improvement, and it suggests that maybe a smartphone app might be a reasonable way to consider administering the low FODMAP diet. This was a study looking at probiotics. So we had an excellent talk yesterday on the microbiota of the gut, and so I thought this was a kind of a nice correlation. They were looking at specifically bacilli class of sporebiotics, and they used the Leuven postprandial distress scale and a change in that to determine whether or not there was appropriate response. So this was a randomized trial. They had 55 patients. They randomly assigned them to either receiving the sporebiotic or probiotic. Probiotic or placebo, and they were either on or not on PPI. And then they had an open label portion of the study as well. And what they found looking at the clinical response over here, so the dark blue is the sporebiotic group, the light blue is the placebo group. They found in all patients with functional dyspepsia, there was a significant clinical response in terms of their change in PDS score in the patients who received sporebiotics. They further divided them up based on PPI use, but didn't see a significant change, though there was, as you can see, a trend to a change. They also looked specifically at the scores, and as you can see, this is the dark group here is the probiotic group. There was a significant decrease in the PDS score and the EPS scores for these patients. And they did breath tests both at baseline and at 8 weeks, and they found that the patients who received probiotics had fewer of them had positive breath test scores. They also looked at inflammatory scales in these patients, and they found that this was baseline, 8, and then 16 weeks, and they found that there was a decrease in IL-17 inflammatory cells and Th17 cells. And there was also a difference in terms of correlation to the PDS score. So as the PDS score decreased, there was a decrease in these inflammatory markers as well. And there was also a decrease in gut homing, Th17 and Th2 cells in patients who had functional dyspepsia on PPI therapy and received probiotics. They also looked at the microbiota, and they found that there was an increase in Faecalibacterium as well as Rosaburia in patients who received probiotics. And specifically, the increase in Faecalibacterium was associated with a decrease in PDS score. And then this was a nice study looking at the squatty potty, which I don't know if any of you use this in your practice, but it has been suggested that it is helpful in some patients with certain defecatory disorders. So this was a study looking at patients who had anal rectal manometry and an abnormal balloon expulsion test. And basically, they had 253 patients with an abnormal balloon expulsion test. All of the patients received then had a repeat balloon expulsion test using the squatty potty, and they found 1 in 7 patients had normalization of their balloon expulsion test with the squatty potty. What they looked at further was to see were there any predictive factors that might tell you who is going to benefit, and what they found that was that males benefited more than females, and if you had an absence of dysenergic defecation, you were more likely to have benefit with the squatty potty. So basically the idea is you might want to consider that if you do anal rectal manometry, perhaps you should include this as something that you might want to actually do in office for those patients who have an abnormal balloon expulsion test. You can then determine if that might be something that would be helpful for them. And then lastly, this is just another descriptive study. This is actually looking at physician visits over a 10-year period for patients with constipation. This is 35 million patient visits over, like I said, a 10-year period from 2005 to 2015. The mean age of patients presenting with constipation was about 58. Majority were female. The race was 82% white, 11% black. Most patients, interestingly, were not on any therapy for their constipation, but those who were, as you might expect, were actually on osmotic laxatives, so that does tend to be the preferred treatment, I think, for most of us. And what was interesting was there was a significant increase in prosecretory prescriptions over time, which you might expect as they become more and more popular. And if you were a GI provider, you were more likely to prescribe those than if you were a PCP, which as well might be expected. And interestingly, they found that the trends in visits for constipation, primary care trends, so the blue line here is primary care visits, orange is GI, and gray is surgery. GI visits have steadily increased over time, over the 10-year period, whereas primary care visits for constipation have actually decreased, and we might expect that. Surgery did not significantly change. And elderly patients, this is looking at age and visits. So the gray line at the top here is 65 and older. This is 41 to 64, and this is 18 to 40. There was a significant increase in visits in our elderly population over time. So we're seeing more and more of these patients. And that's all I have. Thank you.